all. Well, welcome to the Bone Forum, and in your handout, my title is different. It says CKD and fracture risk assessment, but actually, I'm going to be talking about something a little bit more relevant to the world of endo and nephrology, and I'm going to talk about managing or evaluating and treating chronic kidney disease, mineral and bone disorder. So our educational objectives are as follows. So we're going to be talking about CKD-MBD. What exactly is that? We'll discuss the main clinical outcomes that are associated with MBD, management goals, and then approach to treatment. And let's start out with a typical case, okay, of what I may see in my clinic. So this very pleasant 63-year-old postmenopausal woman was referred to me for a history of fractures, and she had 3 spine fractures. So she had back pain one day, and her primary care doctor sent her for back films, and she had fractures at L2, 3, and 4. She had CKD stage 4, so her GFR was 22 per minute. She had a DEXA done, and her T-score at her total spine was minus 2.5. She came to me with some biochemical parameters. So she came to me with PTH, BSAP, and a 25D, and I put the reference levels there for you to see where they fall. In the 25D, the target range for CKD-MBD is about 45. And then the questions that you're asking yourself are, how do you want to treat this? So what drug should you prescribe? But then a very important question for CKD-MBD patients are, what disease do they have? What kind of renal osteodystrophy? So we're going to use that case as a springboard. So let's just talk about this graphic here. And this is the inverted CKD pyramid. Now, these data are old. They're from 2005, but the concept is the same. So CKD prevalence by stage, stages 1, 2, 3, 4, 5, are an inverted pyramid, with most patients in the population having CKD stages 1 and 2. So about 1 in 10 Americans has CKD. The majority of the stages 1 and 2 and 3, and then 4 and 5, there's a much lower prevalence of CKD, and that's because a lot of those patients are dying, and a lot of them are dying from MBD complications, in particular cardiovascular risk and fractures. So what is CKD-MBD? So CKD-MBD stands for chronic kidney disease, mineral and bone disorder. I know it's a clumsy term, but basically it was developed or propagated in 2006. And the reason why is that the idea was to have a term that represents the global disorder of CKD-MBD. So we used to think of everything as just being part of renal osteodystrophy, but the idea for MBD is to actually make it apparent that it's a systemic disorder that involves a bone component, so that's the renal osteodystrophy component, and then disorders of vascular smooth muscle differentiation and vascular calcifications, and then abnormalities in mineral ions, such as phosphate, calcium, FGF23, calcitriol, and in the future we'll probably include sclerostin and DKK1 in that. And we worry about CKD-MBD because the main clinical outcomes that we have to deal with are excessive cardiovascular risk, death, and bone disorders or fractures. The basic pathogenesis to MBD is as follows, and it has to do with abnormalities in vitamin D metabolism and in parathyroid hormone metabolism. So the PTH vitamin D axis is disordered. And this is just a general schematic of what happens in renal failure. Fortunately, my pointer's not working, so I'm going to have to get in front of the board. So basically, you have circulating vitamin D3 bound to the binding protein in the serum, goes to the liver where it's 25 hydroxylated. That then goes into the kidney where the rate limiting step occurs at 1-alpha hydroxylase. So 1-alpha hydroxylase converts 25D to its active form. I'll refer to that during this talk as either active vitamin D, calcitriol, or 125D3. And since 1-alpha hydroxylase is the main rate-limiting enzyme here, this is the one that's highly regulated by the actions of parathyroid hormone, calcium, phosphorus, and very importantly by FGF23, which is a negative inhibitor of 1-alpha hydroxylase. Another component of the pathogenesis of CKD-MBD is disordered phosphate metabolism. So remember that FGF23 is a phosphatonin, and it regulates phosphate excretion in the kidney. It regulates insertion of the sodium phosphate cotransporter in the proximal tubular cell. And when you eat phosphate, FGF levels go up. You shuttle NPT out of the proximal tubular cell, and then you have phosphaturia. Okay, in renal failure, even before phosphate levels rise, very early on in CKD, FGF23 levels increase for unknown reasons, and that begins the cascade of suppression of calcitriol synthesis. And then also, as nephron mass decreases, calcitriol also decreases, phosphate levels increase, and that results in feedback to the parathyroid gland for hyperparathyroidism, and then which then results altogether in more FGF23 production. So there's this vicious feedback loop that results in hyperparathyroidism and excess FGF23 and low levels of calcitriol. When does all this begin to occur in renal failure, and what are the first signs of MBD? And basically, the first signs that begin to occur are that PTH does rise early, and in fact, excellent data from large-scale epidemiologic CKD cohorts demonstrate that even when the GFR is relatively preserved, so at about 80 cc's per minute, about 15% of your patients will have hyperparathyroidism. Okay, and that precedes abnormalities in calcium and phosphorus, which really don't tend to occur until GFR is limited. So GFR, or percent of kidney function, of around 30 to 20% of kidney function, so CKD stage 4. So we don't see abnormal calcium phosphate metabolism in the blood until GFR is pretty bad. Early on, though, in renal failure tracking with the hyperparathyroidism, we do see disorders in calcitriol synthesis, and we see that hypovitaminosis D can occur early on in renal failure, even when the GFR is relatively good, such as a GFR of about 80 per minute. And although at that point, you can say that nephron mass is still preserved, and you should be producing enough calcitriol to suppress PTH function. Remember that FGF levels rise very early in renal failure, and the initiating step to calcitriol suppression is actually the elevated levels of FGF23 that occur early on in CKD. So we mentioned the phosphate and vitamin D part of MBD. What's the vascular part of MBD? So CKD-MBD hyperphosphatemia results in a transdifferentiation of vascular smooth muscle cells into osteoblast-like phenotypes, and they begin to deposit calcium into large and small arteries. Do you guys remember from pathology what Mockenberg's calcifications are? So not similar to atherosclerosis. Atherosclerosis occurs in the intima and results in calcifications of the intima, whereas Mockenberg's calcifications, which are characteristic in patients with CKD and with diabetes, occurs in the media, right? So in the smooth muscle component of large and medium-sized arteries. And as you can see here in this image of a spine, okay, and you see this big blood vessel here is the aorta, you can see it's highly calcified. And this is in a dialysis patient, and this is typical of what we may see. So these dialysis patients are very calcified in their arteries, and this results in tremendous morbidity and mortality, and in part, for a large part of their cardiovascular risk is driven by this. And this is probably one of the main reasons why statins don't work as a cardioprotective agent in patients on dialysis. And if you look at all of the clinical trials that were done that have included dialysis patients, lipid-lowering therapy doesn't help them. And this probably is why, because the pathogenesis of their cardiovascular risk is different from people with healthy kidney function. So phosphorus also, I mentioned, results in this hyperphosphatemia, results in this transdifferentiation of vascular smooth muscle cells and results in this vascular calcification phenotype. At what levels do we begin to worry about this? And there's excellent epidemiologic data indicating that as phosphorus levels increase in renal failure patients, that mortality worsens. And even when, when the phosphate is just barely beginning to come up or beginning to increase over the course of renal failure, we see significant increases in mortality risk, both for the phosphorus and for the calc-phos product. And when we monitor renal failure patients, we usually refer to just the phosphorus and try and keep the phosphorus less than 5.5, which is where all of our epidemiologic data indicates that mortality risk increases. The final component of the CKD-MBD triad is the bone component, and this is classically the renal osteodystrophy component. And renal osteodystrophy is a complex phenotype because it's not one disorder, but it's multiple disorders, and it involves differences or variability in both bone turnover and bone mineralization. So at one end of the spectrum of bone turnover, we have the classic osteitis fibrosa cystica, or what we refer to now more as just high turnover bone disease, and that's represented here in this bone image, where you see a trabecula that has tunneling and it has peritrabecular fibrosis. And if you could see this better, if it was a better image, you would see a load of osteocytes and osteoblasts that are there resorbing and making more bone. Then on the other end of the spectrum, we have what's known as either low turnover bone disease or adynamic bone disease, where the bone formation and resorption rates are just completely shut off, and there's nothing going on. What makes a patient have one of these two disorders or anything in between is unclear. It's something about the patients, the drugs they're taking, their age, that makes them have these disorders, and it's unclear what actually makes that happen. Okay. The main clinical outcome that we worry about with the bone component of CKD-MBD is the fracture outcome. And there's really great epidemiologic data showing that fracture rates in renal failure patients are higher than they are in the general population. So here, these are data from several large-scale databases. These are from CMS data and from USRDS data. Here in black, you have hip fracture rates occurring in the general population, and then in the colored lines, you have fracture rates in patients with CKD stage 3A, so mild dysfunction, 3B in green with more severe CKD, stage 4 in purple and blue, we have our patients on hemodialysis. And as you can see, fracture rates across age groups are anywhere from 14 to 14-fold higher in our most severe CKD patients, meaning those on dialysis. And if I showed you mortality figures, you would see the mortality rates after hip fracture in CKD patients are about 3 to 5 times higher than they are in the general population. And then in terms of costs, hip fracture rates alone in CKD patients result in over $500 million worth of healthcare costs for the U.S. population based on 2010 data. Okay. So when we diagnose CKD-MBD, I broke this talk down into the 3 different components. So diagnosing the mineral component, the vascular component, and then the bone component. Okay, and this is how the Kidney Disease Guidelines Organization breaks this down also, and that organization is called KDIGO, the Kidney Disease Improving Global Outcomes Guidelines. For the mineral disorder, KDIGO asks us to check the main components of that, so calcium, phosphorus, PTH, and 25D. Testing frequency is based on CKD stage. So for very mild renal failure, the guidelines are unclear. If you have a patient with CKD stage 1 or 2, so remember stage 1 or 2 is basically you have normal kidney function, but there's some kind of kidney damage. So whether your patient has polycystic kidney disease or has a glomerular disorder with just proteinuria, the guidelines basically say check a vitamin D and PTH maybe once a year. Okay. For more severe renal failure, so stage 3, when GFR is compromised, typically we check from 6 to 12 months, stage 4 or 5 every 3 months, and then on dialysis, these blood tests are checked actually monthly, okay, by the nephrologist in the unit. So if you have a patient on dialysis, you just need to communicate with your nephrologist in order to get your hands on that data if you're managing their hyperparathyroidism or bone disorder. Okay, and then in terms of diagnosing the bone disorder, KDIGO does say to check an alkaline phosphatase, which happens for patients on dialysis basically every month. But for your earlier stage renal failure patients, you can check them at the same time as you're checking the other blood tests. So then what do you do with it? Okay, so the guidelines for KDIGO are quite murky here for managing the mineral component. For basically stages 3 through 5, and even on dialysis, they state that you should just try and maintain levels of these ions in the normal range. And that can be very hard to do. Okay, so it is not recommended that you preemptively start your renal failure patients on phosphate binders early on to prevent them from developing hyperphosphatemia, because there's no clinical outcome benefit to that. But if your patient has a phosphate of 6, they should be on a phosphate binder. Okay, if your patient's PTH is elevated, you should check what it could potentially be. Check for hypocalcemia, hyperphosphatemia, treat that. Check for low levels of 25D, treat that. And then if the patient's still hyperparathyroid, then consider adding on an active form of vitamin D like calcitriol or Zemplar or Hectorol. And then if you still can't get the PTH down to the goal range, then consider a calcimimetic. Okay. So then, as you're treating these abnormalities in renal failure patients, how effective are these interventions? So if you have a patient with very late stage disease, let's say CKD stage 4, and they're hyperparathyroid and you want to treat them, should you give regular vitamin D, meaning parent D or nutritional D, or should you give calcitriol? Is there a difference? Doesn't matter. Do you know? Want to take a guess? For what? For stage 3, stage 4, stage 5? All stages?
Yeah. Unless from 4 and 5
So there's data on this, and there are a few papers out there, but I just show this data where it's been looked at what point in renal failure should you be giving patients an active form of D, or when should you be treating with nutritional D. So if you hypothesize that the hyperparathyroidism is driven by low nephron mass and an inability to convert 25 to 125, okay, then it makes sense that as renal failure progresses that you should be giving calcitriol for late stage disease, but then maybe for early stage you can manage them with just nutritional D, okay? So that's what these data show here, and here you have CKD stage 3 and 4. You have baseline in the open, and then you have post-treatment here in gray. And these patients were given either a 25D or 125D, and 25D, 125D, okay? And this figure here just shows you that after supplementation with 25D, their D levels went up for both CKD stage 3 and stage 4, and that after supplementation with 125D, their 125D went up. So if they got drug, their levels went up, okay? This figure here shows you the clinical outcome. So for patients here who got 25D, okay, so they got nutritional D, they got D3. Okay, what it shows is that for patients who had stage 3, so that they had a GFR between 30 and 60, the PTH level came down by 15% pre and post treatment, okay? In the CKD stage 4 patients who received D3, there was no change in the PTH level pre and post treatment. So basically what these data suggest to us is that when you have enough nephron mass to convert D3 to convert 25 to 125, you can basically manage their hyperparathyroidism with D3 alone. However, when renal failure progresses, you need to be more aggressive and give them an active form of vitamin D. Okay. And many nephrologists now also will give combination therapy, so you'll see patients who are on both D3, so nutritional D, and an active D analog. Okay, and why is that? It seems redundant, right? And the reason why is that there are putative benefits to being on D3 because 1-alpha is basically in every cell type. And there's some data suggesting that in the bone that mineralization responses are superior to D3 or 25D than to 125D. And there have been studies in dialysis patients and also in patients pre-dialysis showing that they have better mineralization rates and bone formation rates when they receive D3 versus 125. Okay, so a lot of nephrologists now will give both. Okay. So, oh yeah.
Do you typically give high doses like the 50,000 or just the maintenance dose?
So the IOM says that for the population that target 25D should be 20, right? For renal failure patients, we think it should be a little higher. Uremia does impart some resistance to vitamin D and to parathyroid hormone. So we try and ride the D3 or 25D levels between 30 and 40. Okay. In terms of supplementation, we tend to give 1,000 a day or 10,000 a week or 50,000 a month. So very similar to what the general population is receiving. Okay. So in terms of then managing the other components of CKD-MBD, we really worry about phosphate control. And we worry about phosphate control because it's one of the main drivers of hyperparathyroidism, and it associates with mortality outcomes. I showed you that nice figure before showing that when phosphate levels go up, there's a linear trend towards increasing mortality risk. There's excellent data from years ago about how if you take dogs and you give them kidney failure and then you treat one group with a very low phosphate diet and one group with a regular diet that's full of phosphate, that the animals develop hyperparathyroidism. Okay, and that's what this figure here represents. So these dogs here were on a low phosphate diet, and as their kidney function decreased, none of the animals became hyperparathyroid, in contrast to those animals who received a regular diet. And in humans, what we do is this is just to say that phosphate's in everything, and our first intervention to control hyperphosphatemia is to manage diet. But as I said, phosphate is in absolutely everything. It's the main preservative in foods, so it's very hard to get your patients on a low phosphate diet. One of the main food sources of phosphate is dairy, so many of the ESRD patients are basically completely restricted from eating dairy, which is bad for them because then they get no calcium. But our way to control the phosphorus, as I said, as part of diet and then drugs, is to take advantage of the fact that there's a very nice linear relationship between phosphate absorption and phosphate in your diet. Okay? This is just old physiology. Here showing that as you increase what you put in your mouth, you increase what you put in your blood. But what we do is we basically manipulate this system by giving our patients phosphate binders. I assume that you, as medicine people, you've all heard of these drugs, and you've heard of the calcium-containing phosphate binders and non-calcium-containing phosphate binders. So let's talk a little bit about this because this is a very important part of our armamentarium. So they come in multiple flavors, calcium-containing phosphate binders. It can be calcium carbonate or acetate, so Tums or Foslo. The issue with these drugs that we worry about are the calcification risk. So if you have a renal failure patient that has decreased urinary clearance of calcium, there's a potential that you're going to make this patient calcium overloaded, and we're always worried about that because that may drive cardiovascular risk. There are very few calcium balance studies in renal failure patients, but 2 have been published in the last 10 years, and I'll just talk briefly about these studies. So this study was a crossover study that took patients with stage 3 and 4 CKD and a control group of normal renal function. they put these patients on one kind of diet to begin with that had either 800 milligrams of calcium or 2 grams of calcium. They were on that diet for 1 to 4 weeks, and then or 9 days, sorry, and then they crossed over after a washout period of 1 to 4 weeks. And they were all on a very strict phosphorus control diet. What they showed was that in the renal failure patients, that these guys went into very positive calcium balance on the higher calcium diet. So when they had 2 grams in a day, they became very overloaded with calcium. And it seemed that for the CKD patients, that 800 milligrams per day was pretty much a good amount to keep them in normal calcium balance. And why is that? That's because when you decrease your nephron mass, you decrease your body's ability to augment urinary calcium output. So basically, you retain everything. And they did fecal balance studies where they showed that, okay, so when you take in calcium, if you're a renal failure patient, your calcium levels go up as expected. Your fecal calcium levels also go up as expected. However, your urinary calcium does not go up. And all that basically is staying in your body. Where are you putting it? Probably not in your bones, but you're probably putting it in your vasculature and other soft tissue. So based on those data, we were really kind of fidgety about giving patients calcium, in particular if they're on dialysis. And if you're managing a patient, let's say with osteoporosis, who happens to be on dialysis, and you try putting them on calcium, you're going to get into a fight with your nephrologist. So I would just say, talk to your nephrologist about being aware of the importance of not overloading the patient with calcium and trying to figure out what calcium level that your nephrologist is comfortable with. Okay, and I, as a nephrologist, regularly get into arguments about this with referring nephrologists to me. Although I'm an expert in this field, a lot of them just get very uncomfortable with giving calcium to the patients because we see it all the time that the excess calcium can be just dangerous for them.
I have a question. How do you manage the consults when the patients have like coronary calcifications and CKD, and then you want to give them calcium, but then there's a lot of pushback?
So the first thing that I do is try and get it through diet. I think that we can all accept now that taking calcium in your diet is probably a better way than giving them a pill, right? I try and get them to eat about 1 to 2 servings of calcium per day, depending on how overloaded they may be. If they're completely restricted from calcium because they're hyperphosphatemic, then I gingerly give them a supplement of between 250 and 500. And a lot of this is, there's no hard science behind this, but if they have severe bone disease and they're totally restricted from anything that contains calcium, you have to try and figure out a way that you can safely give them something. Whether it's going to be a small dose tablet, or whether you work with your nephrologist about increasing the calcium in the dialysate. Okay, there are a number of ways that it can be done, and it's best to discuss this with the nephrologist.
Would they have an argument about increased mortality because of coronary reasons, like if they have coronary calcifications and then they're trying to give them calcium like in the dialysis? How do you address that if they say, oh, are you going to increase my cardiovascular mortality?
Well, if they're not eating any calcium, and so if they have severe osteoporosis and you're trying to prevent a fracture from occurring, then it's like, well, they're going to break their hip and die, or they're going to have a cardiovascular event if you overdo it. Let's just figure out what level of calcium supplementation we're all comfortable with. Now, we're not going to give them 500 milligrams. Let's give them 250 milligrams a day or something. So I just go towards the very low end of the spectrum of supplementation. It's a difficult question. So how about the non-calcium containing phosphate binders? So this list only contains 3. Now there are 2 more, which I won't discuss because they're not really in clinical, they're not really used that much yet. There's sevelamer, lanthanum, and then aluminum hydroxide, or otherwise known as amphigel. So sevelamer is a polymer, binds phosphate by ion exchange. There's no calcium in it. It works very well, and this is probably the most commonly used phosphate binder in the current era. Lanthanum is a rare earth element, also binds phosphorus effectively. We use this less because it comes in a big tablet that's like about this size. It's hard for the patients to swallow. It can't be crushed. The nice thing about sevelamer is that it comes in packets also. So if the patient can't swallow the tablet, you can get them to pack it, and then they can kind of like spread it over their food, and it's tasteless, so it doesn't affect the taste of the food. Amphigel, we don't use anymore, except for certain circumstances. It's a very effective phosphate binder. And in patients with severe hyperphosphatemia, it works really rapidly. However, the issues with aluminum-containing phosphate binders and aluminum in general are that they cause dementia, and also they cause a really nasty form of osteomalacia. So that drug fell out of use about 20 to 30 years ago. We do still use it in like very, very rare circumstances. Like if we see a patient who has a serum phosphorus of 20 for some reason or another, and we want to get the phosphorus down rapidly because we're concerned about calcium phosphorus deposition in the cardiac conduction system, we can give like a 2 or 3 day course of Amphigel, just get the phosphorus down, and then stop it and just avoid it. Although dialysis is also a very effective way of getting the phosphorus down instead of Amphigel. Let's see. Does it matter which phosphate binder you use? So I've just given you a big talk about calcium versus non-calcium and our fear about the risk of cardiovascular mortality and calcium overload. Has it ever been shown that a non-calcium containing phosphate binder imparts any kind of a mortality benefit to renal failure patients? Anyone want to take a guess? No, I got one no. Any yeses? So the answer is no. So there have been multiple, nephrology is a terrible field because we have the least number of randomized clinical trials of any medicine subspecialty. And we have a number of small little trials of phosphate binders comparing calcium to non-calcium containing phosphate binders. Some are positive, some are negative. And we have 3 large meta-analyses. The last meta-analysis showed a mortality benefit of about 20% for a non-calcium containing phosphate binders. But the most recent meta-analysis that came out about 2 years ago involved maybe about 80,000 patients over multiple centers, dialysis centers, multiple data sets. And they compared sevelamer, lanthanum, calcium. There's a new iron-based phosphate binder that just came to market. There's another one based on cholecystolin, and then of course placebo. And this complicated little graph, okay, just basically you read it going from left to right. So in the first box here, you're comparing sevelamer to lanthanum, okay, sevelamer to calcium, and then so forth. The only thing that came out is that it seemed like there was maybe like a 60% benefit for mortality for sevelamer versus calcium. However, that didn't come out for any other comparison. And then compared to placebo, there was no mortality benefit. So the data is still really unclear. One would hope that compared to placebo that you would have a mortality benefit, but that didn't show up either. So the data is still out, but the feeling in the community is that we try and just stay away from calcium. Okay, we try and just give a non-calcium containing phosphate binder. How about bone? And this probably is one of the most controversial areas of MBD management, and this has gone through the most changes. So the last round of guideline updates that came out about a year ago really shook the field up in terms of how to manage the bone problem in CKD-MBD. So up until a year ago, DEXA screening was not recommended in CKD patients at all because there were no studies indicating that it predicted fracture. Okay? As I mentioned before, nephrology is great for small studies and not great for big studies. Now we have a bunch of big studies, though, that show that DEXA predicts fracture in CKD patients, and that guideline was upgraded to say that basically any patient with CKD should receive a DEXA. Okay, so the guideline actually states that if you have a CKD patient with mineral and bone disease and risk factors for osteoporosis, as in the general population, that they should be screened for fractures with the DEXA. So if you figure your CKD patients, they're going to be old, they're going to be frail. A lot of them are going to be on immunosuppressants for autoimmune diseases, so they're going to be on steroids. So basically, all of them have risk factors that we would screen for, right, for osteoporosis. So that guideline's graded as 2B, which is, you know, not the best grade, but it's pretty strong. The KDIGO guidelines also recommend that in renal failure patients that although you can screen for fracture risk with a DEXA, it's very important to know the bone turnover because that's going to affect your treatment management. Remember that renal osteodystrophy is a spectrum of turnover, so you need to know what the turnover is, and you can do that with getting a PTH or a bone alk phos, and that is also graded as 2B. And then if you have to, because the bone biomarkers aren't working so well, you can get a bone biopsy if you can get it. Very few of us can. And that guideline is not graded, and it's not graded because it's hard to get a bone biopsy. So KDIGO did not want to give that a high grade, indicating that it should be mandatory.
If you suspect adynamic bone, would you suspect adynamic bone disease if you had like a stage 4 but a normal PTH?
So the old paradigm for treating the bone disease and renal failure patients was very PTH-centric, and we were always told, check the PTH. So for dialysis patients, I think that's the easiest example. You know, check the PTH. If it's high, put them on vitamin D or put them on a calcium mimetic. Okay, monitor the PTH, and if the PTH is still high, give them more drug. If the PTH is low, or like it goes below the threshold that the guidelines recommend. And for dialysis patients, the guidelines recommend keeping the PTH between 2 and 9 times the upper limit of normal of the assay. Okay, so if your assay upper limit of normal is 65 for the intact PTH, so if your PTH goes below 130, that means that you should shut off the drugs, right? Or if your PTH goes above, 700, okay, for the upper limit of normal, then you should start the drugs, okay, and keep the PTH sort of in that guideline. And the assumption was that, oh, okay, so this will treat their renal osteodystrophy and will keep patients safe. But that never panned out, and fracture rates in renal failure patients continue to go up, okay. So the guideline change for DEXA, telling us that now we should be getting DEXAs, kind of changes that paradigm. The guideline then basically asks us to assess fracture risk, then to assess bone turnover, and then to manage the patient based on the bone turnover. In the background, you're managing MBD. In the background, you're always managing vitamin D, hyperparathyroidism, and the phosphate. Now the guideline is asking you to manage the osteoporosis. And you do that with drugs that either shut off resorption, so if you have high turnover, you can use an anti-resorptive, and if your patient has low turnover, then you can use an anabolic agent. So the guideline results in a bit of a shift in how we think about managing renal osteodystrophy.
I have a question. For the patients with low bone turnover, is there a certain, if you do use an anabolic agent in a CKD patient, is there a certain PTH level at which you feel comfortable giving an anabolic agent?
So I actually think that it's okay to give an anabolic agent even if your patient is clinically hyperparathyroid. But if they have low bone turnover, remember that there's PTH resistance in uremia. So that means that the PTH just isn't high enough, and they need more of it. Okay, now you can peel back on the vitamin D, and you can peel back, and you can make them more hyperphosphatemic, although I wouldn't really recommend that. But then even if you can raise the PTH a little bit, it may not be enough, and a lot of them still have low turnover. Then a lot of the low turnover in renal failure does occur secondary to parathyroidectomy. So you'll see it in your dialysis patients. And those guys will have, like a PTH that's maybe high limit of normal, but they just have no bone turnover. Or you may have transplant patients who are always hyperparathyroid. About half of transplant patients remain hyperparathyroid for the long term. But because of their drug regimens, that they get low turnover or adynamic bone disease, and they need more PTH to stimulate bone anabolism. So the management dilemmas for CKD or renal osteodystrophy or CKD-associated osteoporosis are that you have to figure out how do you interpret the BMD, okay? Then you need to decide whether you can perform invasive or non-invasive bone turnover assessment. So what do these PTH and BSAP levels mean? And then how do you use this data to manage fracture prevention and treatment strategies? So the first thing is the easy one, so DEXA. So now we have very nice large studies of DEXA predicting fracture in pre-dialysis, dialysis, and transplant populations. And they all pretty much say the same thing. So I'm only going to show you the data for the pre-dialysis population. So this data came from the Health ABC study. Health ABC, large cohort of community dwelling adults, elderly people. They enrolled patients who had some renal failure. They looked at DEXA at the hip and at the spine. Okay, they didn't look at the forearm. They looked at T-score. They looked at how the T-score divided by standard deviation could predict fracture in these populations. And they compared CKD, which is in yellow, to healthy kidney function in blue. They had models that were unadjusted, adjusted for typical demographic factors, and then adjusted for the things that we worry about for renal failure, like PTH and vitamin D. And they showed that prediction was the same, okay, with femoral neck T-score. And because they used the T-score and they were using the WHO classification system for osteoporosis and osteopenia, they also demonstrated that the cutoffs that we used for the general population worked the exact same as in renal failure patients. This data was replicated once again in dialysis patients and in transplant patients. And basically, the data states that you can use DEXA and you can just use your T-scores, and that's going to be as predictive in CKD patients as in non-CKD patients. So it's a great screening tool. Everybody has DEXA, inexpensive. Okay, so that's easy. Okay. They did lumbar spine also, not predictive. And can anyone guess why lumbar spine would not be predictive? Perfect, yeah, the calcifications. It biases the image result. So lumbar spine's not a great site. And that also came out in dialysis patients too, okay? And then they didn't look at forearm. In dialysis patients, there was a forearm study, and the forearm worked great. So you can do hip, forearm, they work equally well. Oh, this is the dialysis data. These are the AUCs, and as you can see for hip, forearm, great AUCs for fracture prediction, pretty similar to what they are in the general population, and then lumbar spine BMD, not predictive, probably for those exact same reasons as we just mentioned with the vascular calcifications. Okay, so moving on to the bone turnover markers as a tool to assess bone turnover. This is a little bit complicated because these are, it's not 100%, and this is where the art of medicine comes in versus the science of medicine. So most bone turnover markers are cleared by the kidney, so osteocalcin, P1NP monomer, and CTX, renally cleared. So if you have a CKD patient with high levels of these markers, it may be because they have bad kidney function, it may be because they truly have high bone turnover. It's hard to know. The turnover markers that are not renally cleared are bone alk phos and the P1NP dimer, or the multimer. Okay, so those you can measure in CKD patients, and they should give you an accurate representation of bone formation. In osteomalacia, BSAP may be very high. So if you check a BSAP in a patient with osteoporosis, and the BSAP is very high, it could be high turnover bone disease, or it could be osteomalacia. Because that's one dilemma. Reference ranges don't exist for CKD patients. So I know like in postmenopausal women, you guys are using the premenopausal reference ranges. We use those in CKD also, but we don't know how well they work. And there's some data suggesting that BTMs may be predictive of fracture in renal failure patients, and studies in dialysis patients indicate that high levels of BSAP are actually better as a fracture predictor tool than DEXA Okay, but we don't have great cutoffs for those levels, and that data has not been replicated in multiple cohorts. So the main thing with the BTMs is, what do you do with them? And KDIGO recommends that we use parathyroid hormone and bone alk phos as our main markers of bone turnover. Okay, and there are better data in ESRD patients from which these data come from than in pre-dialysis patients. But in the pre-dialysis data sets, the data looks very similar to this. So I'm just going to talk about the dialysis cohorts. Okay, so in your standard assessment of bone turnover in an ESRD patient, you check a PTH and a bone alk phos, and then your goal is to basically differentiate low from non-low and high from non-high, because that's where you basically have that fork in the road about how you treat somebody. Do you give an anabolic or do you give an anti-resorptive? So the AUCs for these biomarkers are okay. I mean, they're not great. So in terms of differentiating low from non-low, for PTH it's 0.7, BSAP 0.75, and when you combine the two, it doesn't give you any added benefit. Okay, the cutoffs for these biomarkers for low versus non-low, the best cutoff was about 103 and 33 for PTH and BSAP, and the KDIGO cutoff, if your intact PTH assay has an upper limit of normal for low versus non-low, was 130. So not too far off. Okay, for high versus non-high, the AUCs were 0.72, 0.71, and once again, no increase in accuracy for combining them. The cutoffs here are 323 for the intact PTH, but the KDIGO cutoff is much higher, okay, at 620, and then for BSAP it was 42. Why this difference here? So this KDIGO cutoff was based on, not on hard outcome data, it was based on observational data in large dialysis cohorts that showed that mortality rates and fracture rates had a U-shaped phenomenon and basically began to go up when the PTH was around 620. So it's not really based on any hardcore clinical data. In terms of operationalizing this, in terms of when do you start therapy, when do you stop therapy, now, this is all dialysis. This paper, or this biopsy cohort, looked at the KDIGO cutoffs and then looked at the diagnostic test characteristics. So in terms of thinking to yourself, oh, when do I start therapy in an ESRD patient? So here on the bottom, you start therapy when the PTH rises above the cutoff, which is 9 times the upper limit of normal. But as you can see here, the sensitivity specificity aren't that great, meaning that PTH is an okay biomarker. I mean, its AUC was 0.7, but it's not. It's great. I mean, we need to do better. I mean, and in terms of stopping therapy, PTH works a little bit better. So stopping therapy, if your PTH goes too low, you think to yourself, oh, I've suppressed bone turnover too much. I should pull back on my vitamin D or cinecalcet. The diagnostic test characteristics were a little better than for down here. However, not fantastic.
I'm sorry, so you're saying you only start therapy when PTH is above 600?
This is dialysis. Okay, so in dialysis cohorts, the goal is to maintain PTH in that range. Okay, so 2 to 9 times, and typically what we're doing is we're manipulating the whatever active vitamin D analog that our unit is using, and we're always changing the dose to keep the PTH in that range. So we're not really starting therapy only when the PTH goes above 650. Typically, they're already on the PTH, and then we're just keeping the PTH below that threshold. So the analysis that's presented in this paper was a little bit artificial, but the concept is that PTH it's an okay biomarker. It's not great. Okay. Now you had a question though, and I'm not sure if I answered it regarding low turnover.
Yeah, I guess if you have a stage 4 patient who fractured, but their PTH isn't as high as you would expect a stage 4 to be, would that tell you something about?
So typically what we do, and once again, in renal failure, there's poor data. Okay, we check a PTH, check a bone alk phos. If your PTH and if both of the biomarkers are low, then we interpret that to mean that the bone turnover probably is low. Okay, versus if they're both high, that probably the bone turnover is high. PTH is really not the best biomarker of bone turnover. It's okay, but
Because I wonder too, like if it's high, you would also suspect PTH resistance, maybe at the bone level, and also have low bone turnover in that way, and it can be interpreted both ways.
so that's the big dilemma in renal failure. So what do you do when your assays are discordant? And those are the cases when we would recommend getting a bone biopsy. So if you ever have any doubt in your mind about what the bone turnover actually is, that's where we say refer for bone biopsy. But out in the population, that's hard to do because bone biopsies are available only at a few centers. I think there are like 5 in North America. So in terms of generating population-wide guidelines, we try and get away from being so dogmatic about how to interpret these biomarkers. So then treating the renal osteo component of this, once again, we always start by treating the MBD, so treating the PTH, the calcium, phosphorus, and D. We discussed the importance of knowing the turnover beforehand. You don't want to give a patient with hyperparathyroid bone disease more PTH, and you don't want to give a patient that has no bone turnover an anti-resorptive because probably it's not going to do anything anyway. So it's really important that you know the bone turnover, and then choose a drug that you think is going to be okay. So bisphosphonates have in the past, there's this hard, black box warning on, the bisphosphonate drugs about GFRs less than 30, and you shouldn't give them. Do you know why that black box warning is there? What's the issue with the GFR less than 30? Are bisphosphonates nephrotoxic? It's a trick question. Yes, both. Yes and no. So the IV bisphosphonates can be nephrotoxic. So permidrinate can cause FSGS, and reclass can cause ATN. Now, the ATN association with reclass was related to the infusion rate. And when reclass was first developed, it was given over 15 minutes, and it resulted in a significant amount of ATN. Now, I think people are infusing it over 20 minutes to a half an hour. I actually have had 2 cases of acute kidney injury in patients who have gotten reclassed. One of them had a GFR of about 20, and she went up on dialysis. And another guy who I treated, who I just gave an infusion in February, was a transplant patient who had a GFR of like 50. And he went into acute kidney injury, and he's still recovering. He hasn't gone into dialysis, but he's still recovering, and his creatinine it was 1.5, and now it's 2.5, and I'm hoping that it comes down, because otherwise I'll be really angry. So I actually now stay away from IV reclass in any patient that has kidney failure. I don't get permidrinate because of the FSGS association.
And that's idiosyncratic?
Yeah. Idiosyncratic. Now the ATN case with reclassed, the guy was in the hospital like about a month prior. He had pneumonia. It seemed like he wasn't drinking. He was dehydrated, although we prehydrate. So like I'm not so clear what would happen, but it's the only thing that we can think of that gave him the ATN. So I don't like giving the IV drugs to the renal failure patients. The oral bisphosphonates have never had any association with acute kidney injury, ever. Okay. The issue with the oral bisphosphonates or with any bisphosphonate are that they're cleared by the kidney. So when GFR goes below 30, you're going to have more bisphosphonate that you're going to have circulating, and these drugs, they go to bone, they deposit there, they stay there, and if your kidney is impaired, that drug's going to be there for a long time. And since we all worry about the long-term effects of antiresorptives and suppressing bone over too much, you have to be very careful giving these drugs to your renal failure patients. I think that you can give the oral bisphosphonates to your drugs, but what we tend to do is we dose adjust them. So rather than giving a weekly dose, we'll give maybe a monthly dose to an ESRD patient, or maybe you'll give every other week to like a stage 4, 3B patient. However, we do think that they're okay to use in CKD patients as long as you recognize that they're cleared by the kidney and that you should dose adjust. Denosumab is a great choice as an antiresorptive because it's not cleared by the kidney. The only issue that you need to worry about with denosumab, in addition to everything that you normally worry about with denosumab and long-term use of it, is hypocalcemia and also reactive hyperparathyroidism. So when you give your renal failure patients DMAB, you should just make sure that their calciums are a little bit on the higher side of normal. You should make sure that their vitamin D replete, and you really need to make sure that you check for safety their calcium levels about 10 days after you give the drug. Okay. It tends to be that the severity of the hypocalcemia is directly proportional to the severity of their hyperparathyroidism. So if you have a really hyperparathyroid patient and you give them DMAB, it's like giving them a parathyroidectomy because they will get hungry bone syndrome. And their calcium will drop. And if you have a patient with mild renal failure and you check a PTH after you give them DMAB, you will see the PTH go up. Okay, your nephrologist will begin to freak out. You will tell them that it's okay. There was a case of a friend of mine who does a lot of MBD work in Chicago, was referred a patient who had a parathyroidectomy and had hypoparathyroidism because the CKD patient had gotten DMAB, developed hyperparathyroidism just as a reaction to the DMAB, and the nephrologist wasn't aware that this has a complication and pulled up the parathyroid glands. And when it was not necessary because there was just a reaction to the DMAB. The PTH level will come down over the course of the 6 months. Okay. And then, for the anabolic agents, as I mentioned, you should make sure that you're not giving these to patients that already have high turnover because you're just going to be making their bone disorder worse. But when you do give a drug like teriparatide or now abaloparatide, there is a risk of hypercalcemia and hyperuricemia. And this also feeds into the nephrologist's paranoia about calcium. We hate hypercalcemia. And then hyperuricemia also is a problem for us because hyperuricemia in renal failure patients also increases cardiovascular risk and can also result in more renal failure progression. So really important that you monitor uric acid and calcium in your teriparatide patients. So first thing I said, treat the MBD. Just by treating MBD alone, hyperparathyroidism alone with calcitriol, you will help their bones. Okay, so there's nice old data showing that when you have patients with renal failure and these patients were on dialysis, they were hyperparathyroid and they received calcitriol and the PTH level came down. Okay, and here they used osteocalcin as a bone biomarker, and although it's renally cleared, the levels went down, indicating that bone turnover was suppressed. And then in terms of their change in BMD, there were significant changes in BMD at the femoral neck and at the lumbar spine in the patients who received calcitriol and had PTH suppression. So the first thing that you always do, treat the MBD and then move on to a big bone active drug to keep them from getting a fracture. Okay. And there are, once again, this is nephrology, so we have no primary data. There are secondary analyses of the main registration trials for all the osteoporosis drugs that have basically selected cohorts, sub-cohorts for the main cohorts where there was some kidney dysfunction. The caveat here is to recognize that these were studies of patients, mostly women, who were screened out for having overt kidney failure. The entry criteria were based on serum creatinine, and the upper limit of normal for inclusion was a serum creatinine of 1.5. Okay, so that's not really kidney failure. No one could have hyperparathyroidism, and they all had to be vitamin D replete. Okay, so if you apply the MDRD formula to a woman who is 80 years old with a serum creatinine of 1.5, she's going to have a little bit of CKD, okay? Probably just age-related declines in kidney function, not really CKD. None of these patients had CKD-MBD, right? Because none of them were hyperparathyroid, none of them were D deficient. However, when you look at just the creatinine clearance or the GFR and you stratify it by different levels, you can see from these data that the drug, in this case, this was, which drug was this? Resigenate, that there was a protective effect in those patients who received Resigenate compared to placebo, and that regardless of kidney function, that effect was present. So that's the bisphosphonates, and this kind of analysis has been done for all the other bisphosphonates, and the data is identical, so I'm not going to go over them. And then also for, this is the teriparatide study, the exact same analysis was done with the teriparatide, the exact same issues with the study in terms of whether or not the patients really had kidney failure is debatable. However, when you stratified them by a GFR of 80, well, not really renal failure, there was a protective effect against vertebral fracture and non-vertebral fracture that was independent of kidney dysfunction. Okay, and the same exact thing was done for the denosumab data, and it's the exact same kind of figure. Okay. So then, I guess, how do we put this all together and then operationalize this? And let's go back into the case. Okay. So I didn't give you all the other data that I had for this case when I saw the patient. So I mentioned that she had a GFR of about 50, that the vitamin D was 40. Her PTH when I saw her was 30, okay? And the upper limit of normal on that assay was 65. And when you're looking at renal failure patients or thinking about them, you should think about them also longitudinally. So you should try and get some measures, there's more than one measure, okay, to get an idea of what's going on with their bone health. So I was able to get PTHs for about a 2-year time period, and her PTHs were always 30. So I know that in the past she didn't have bad hyperparathyroidism, and now she's not, okay? Her calcium was normal, phosphorus was normal, her bone alk phos was 15, and her CTX was 341, okay? So in her case, the BTMs are probably more interpretable because she really had mild dysfunction. Okay, if her GFR was a little bit lower, let's say it was like 30, then the CTX maybe would not be as interpretable. In particular, if it was very high. But anyway, so here I view this as being that her bone alk phos was sort of highish and her CTX was kind of lowish. So I had a little bit of trouble understanding what that meant. But in the setting of a low PTH, I thought, well, maybe this is, I don't know, low turnover, but I wasn't quite sure. And then her DEXA scores are here, minus 1.5, minus 1.3, and 0.1. So what would you do here? Anyone want to take a shot? Would you empirically treat, or would you? Yeah, she had three vertebral fractures. Yeah.
Would you do a bone biopsy since there's some discordance between the bone turnover markers?
So we have one bone biopsy. Let's do a show of hands. Who would just trust the bone turnover markers and say, okay, who's going to call this high turnover and just give her an antiresorptive? Who's going to call it low turnover and give her an anabolic? Who wants to get a bone biopsy? Okay, so she got a biopsy. And she got the biopsy, and this was the biopsy result. And what do you think that is? Is that cortical bone or trabecular bone? Have you guys had the bone biology? Oh, you haven't? Okay, I'm sorry. Okay, so this should be cortical bone over here. So you should see like a nice thick piece of bone. I should have showed you a normal piece, I'm sorry. Usually I give this talk at the very end of the course. So she had complete trabecularization of her cortex, okay? She had normal trabecular microarchitecture, and her bone formation rate was moderately reduced. So here you have bone, that's what this green area is. You have osteoid or bone protein that's lining the bone over here, and there's not a cell here. So although they said it was low normal, in this piece of bone that they gave to me, or this picture, there wasn't an osteoblast or an osteocyte, okay? So she had kind of like low normal turnover, and she had, for some reason, she had complete trabecular, so her cortex was like eaten away. Unclear why. Because she was never hyperparathyroid as far as I knew, unless at some point in the distant past she had hyperparathyroidism and was treated for it. It was unclear to me. So just based on the fact that she had low bone turnover, I was apprehensive about giving her an anti-resorptive, so I gave her an anabolic agent. I gave her teriparatide. This is one of the first cases that I treated, so I very cautiously checked the DEXA 6 months after I began treatment, and she had significant increases in bone mass at all of her skeletal sites. And then I did do a repeat bone biopsy a year after she began treatment, and she had improved her cortex. She had also an improvement in her bone formation rates, and she hasn't had a fracture since. She's actually done very, very well. Now, just going back to the case, okay, now I'm lucky. I mean, I can do bone biopsies here. I do them. We have David Dempster here. We send our biopsies to him. But I don't know where you all come from, but I don't think that probably you come from places where it's easy to get a bone biopsy. Is that a good assumption? You're saying yes?
Yeah, we're doing a
Oh, okay, all right. But they have a big bone group there. But there are other places where maybe they don't have them. So just interpreting these values here. So the bone alk phos is on the high end of normal. So when we look at these, so the PTH is kind of like in the middle. Okay, so really hard to know what that means. The bone alk phos is kind of high normal. Okay, so one would think that, okay, well, there should be something going on there in terms of osteoblast function. She should have like good bone formation rates. But the CTX is low. And what I mentioned before about her GFR being in a range that should make these interpretable is true. So if her CTX is low normal, then you have to wonder, okay, so that's a real low normal CTX, and maybe there isn't much resorption going on. So maybe her bone formation rates are going to be low. And that's exactly what the bone biopsy told us. So years ago, this case would have confused me because the turnover markers seem a little bit off. But now, after seeing so many of these patients, I know that when the CTX is low in a patient like this, that you can really rely on that, and that can inform your management. Now, of course, it would be better if both of these were low, and if this was very low, like if this was like below the reference range. That would be great. But that's not the usual scenario.
On these patients, do you lower also the calcitriol as well, just to see?
She wasn't on. So I'm sorry I didn't tell you this, but she was not on calcitriol. She was on nothing. And her vitamin Ds are normal. But in answer to your question, if you do have a CKD patient who you think is being overtreated with calcitriol, then you should pull back. Okay. Are there other questions about this case or about these numbers? Because this can be very hard to manage, and you guys are going to be seeing more of this in the future. Now that the CKD guidelines have been updated to recommend DEXA screening, I think you're going to be seeing a lot more of these cases. So I think it's going to be important that you just become familiar with how to interpret these data in the context of kidney dysfunction.
What do you do long term? So you put them on teriparatide for 2 years.
Yeah.
Then do you end up putting them on denosumab afterwards, or do you watch the bone turnover markers? And what do you do if they go back into a low turnover state afterwards?
So that's a big. Those are some great questions for which there are no clinical trial data to answer. So I can give you anecdotal answers. Okay, so you treat with teriparatide for 2 years. Okay. Over that 2-year time period, I monitor their bone turnover markers. I make sure that they have an increase in the turnover markers. I will check a DEXA yearly. You can get it covered by CMS if you tell them that they're a renal failure patient or a transplant patient. They will cover a yearly DEXA. And then at the end of that therapy, I reassess the whole entire case. So when you stop your anabolic agent, you do need to do something. And the question is, what do you do? And in many cases, I will continue on with an anti-resorptive. Whether it's a bisphosphonate or denosumab, depends on a number of factors. What's their kidney function? There's data now on denosumab and risk of vertebral fractures when you come off. So I also include what's their T-score at their lumbar spine in terms of which drug I use. Yes?
Do you check the alkaline phosphatase during the anabolic treatment?
I do check it. Yeah, it does rise. I mean, the kinetics of what happens to the bone turnover markers for the case report data that we have in renal failure seems to mirror what's going on in the general population.
In this case, we are not worried that it's going high. I mean, start high, so go over the normal level.
Right. So the BSAP does go up, but then it does begin to come down over time, even on treatment. So there's that anabolic window.
Sorry. Is there really no data supporting risedronate over the other oral bisphosphonates in CKD patients, or are they all equal?
There's no data supporting any one over the other. Yeah.
Okay.
Why do you ask that question?
Some bone attendings say that there is some small risedronate data that supports it over, certainly over abandronate and over alendronate, but I haven't found it myself.
In CKD or non-CKD patients?
In CKD specifically patients. Yeah.
There's no, unfortunately, there's no fracture outcome data for any of the bisphosphonates in renal failure patients.
So you mentioned that the IV bisphosphonates can be renotoxic. So are the oral bisphosphonates known to not be renotoxic at all?
So there's never been a case report of acute kidney injury with an oral bisphosphonate. Okay. And given the millions of people who have received the oral bisphosphonates and no case reports, I would assume that one could say that it's known that they're not nephrotoxic. Okay. So just to summarize, a couple of things to remember. MBD, it's a systemic disease, so no longer is this just renal osteodystrophy. Think of it as a global disorder of mineral, bone, and the vasculature. The clinical outcomes for MBD can be pretty severe, so think cardiovascular risk and bone fractures. We manage the MBD component by controlling phosphorus, calcium, and vitamin D. And then the bone component is unfortunately kind of complex. It can be hard to manage, and it requires that you not apply the general population osteoporosis guidelines to these patients, but that you sit down and think through it, think about their bone turnover, and think about which drug may be appropriate for you to use. And if you can get a biopsy, the bone biopsies in these patients can be very helpful, at least for starting your therapy. Yes?
So other than cost, is there, for the majority of cases where you're not calcium deficient, is there any situation where you would use calcium carbonate or the calcium-based phosphate instead of cebalamine?
Yeah, so there are some renal failure patients who are hypocalcemic. And in those patients, they're hypocalcemic and they're hyperphosphatemic, and in those people, we tend to give a calcium-based phosphate binder.
CKD patient, you would recommend, you would almost always choose cebalamine over.
Yeah, assuming that your patient is not hypocalcemic, the go-to drug right now is a non-calcium containing phosphate binder, and that usually is sevelamer.
What is the lowest GFR that you will feel comfortable using an anabolic?
The lowest GFR? I have patients on dialysis who I use it. Yes?
Concern about calciphylaxis when you're repleting vitamin D or these things? I know it's relatively rare, but I've seen a case, so now I'm scared. I'm just curious.
What was your PTH?
Oh, I don't remember. This was actually when I was a medicine resident, so it was already happening, and all I remember is what his lesions looked like.
Yeah, they can be. Calciphylaxis is pretty bad. Yeah, we do worry about calciphylaxis and when we're giving calcium and vitamin D and calcitriol. However, calciphylaxis typically occurs in patients who are really severely hyperparathyroid, like in the thousands. You don't really see calciphylaxis in patients who are, have normal PTH for a dialysis patient. So like a PTH of like 300, on one of the active D analogs. It's rare to see it in that setting. And usually when they have calciphylaxis, the pHs are so high that we're talking about whether or not it's beneficial to do parathyroidectomy, whether or not, calcimimetic would be the best therapy. Typically they also are hyperphosphatemic. So we're managing multiple components of this axis at the same time. But you should always worry about hypercalcemia when giving any of these drugs, in particular the active vitamin D.
Did you say is the GFR cutoff at which CTX or NTX are reliable to use?
So it's unclear, okay? But usually we see that when uremic toxins begin to accumulate, it's around a GFR between 20 and 30. So I would say starting in that range is when I would begin to interpret the CTX in light of it being renally cleared.
Okay.
So in other words, you may find that you can have, and I've seen this, where you have a patient with adynamic bone disease with a CTX of like 700. So if you have a dialysis patient and their CTX is 5,000, and the upper limit of normal being, I think it's like, 650, right, depending on your assay. If your CTX is 5,000, that probably really represents either normal or high bone turnover. It's probably not going to be low turnover. But if your dialysis patient has a CTX of, in the normal range, that actually may not be good. Like that may represent low turnover or no turnover. Any other questions? Okay, thank you very much.
Thank you.
Yeah.